It's my pleasure this night to welcome Professor Wesam Ismail. And this is a new template for us, Clinicopathology Case discussion by using the voting system. And Professor Wesam prepared a very interesting case that we did discuss before. And after ending of Professor Wesam Ismail, I'm going to give a short talk about the update of the diagnosis of the case. I'm not going to say the diagnosis before the case. Before starting this session, I would like to welcome all my professors and colleagues. Special appreciation for the presence of Dr. Sami with us from Mayo Clinic. He is an expert in the nephropathology, so it is a very nice opportunity to have him to share in the discussion. I would like to appreciate the efforts and sincerity of Professor Wesam Ismail. She enriched our pathology lab, and I think all nephrologists are nowadays aware of the pathology, clinical nephrology and transplantation because of the treasure left by Professor Wesam Ismail through 15 sessions, more than I think 25 hours for nephropathology. So today there is no excuse for any colleague working in the field of nephrology and pathology to know the language of pathology, because we should know the language of pathology to be good nephrologists. And I'm going to leave the mic to Professor Wesam to start her case. Professor Wesam.
Thank you very much for an overrated introduction as usual. Okay, today, as I said, we will start a monthly interactive clinicopathological session, and we have decided on a format for the presentation of these cases, and going to upgrade, and each month we'll present a couple of cases. Today going to be a single case because I said today is just what we call a demonstration session. And if anyone has special feedback on the format or how you would like, please contact either me or Dr. Hussein after the Zoom session with any constructive comments you could have. Okay. So our case is a 13-year-old male student who was complaining of reddish coloration of urine for 6 months. The condition started 6 months when the patient started to develop, just a second, not seeing the full screen, started to develop recurrent attacks of hematuria throughout the urine stream. Each attack was lasting for about 1 day, followed by spontaneous resolution. The attacks were not preceded by urinary tract infection or any form of strenuous exercise. The patient sought medical advice where routine labs were ordered. His urine analysis revealed red blood cells in the range of 50 to 60 per high power field and protein 1+. He was given antispasmodics and urinary antiseptics with no improvement in his condition, and so was referred for further assessment. He has a history of tonsillectomy 2 years ago, no relevant family history, and his physical examination showed no abnormalities. As I said, his urine analysis showed, on a later test, showed 70 to 80 per high power field, PT, PC, INR were normal, dysmorphic red blood cells were negative, urine for acid-fast bacilli was negative, 24 hours urinary proteins were 0.9 grams, hemoglobin electrophoresis showed a normal pattern, ANA, double-stranded DNA were negative, his kidney functions were normal. His sonography showed normal-sized kidneys, and a spiral CT of the urinary tract showed no abnormalities. So now we have a 13-year-old male with recurrent attacks of hematuria. So if this is the differential diagnosis, which one you think would fit into this scenario? What would you think of first?
So this is voting, and would you please click on the choice? Okay, perfect. So we'll give 1 minute for voting, Dr. Wesam.
Sure.
Okay, so 1 minute for voting, and then we go ahead. So this is do you see the results, Professor Wesam? So, 56% IgA, 2 selected Alport, and 6 benign familial hematuria. So these are the 3 choices selected by the audience. Would you like to go ahead, Dr. Sam?
Yes. So the commonest differential diagnosis you guys had in mind, IgA nephropathy and benign familial hematuria, with the Alport syndrome only 10%, C3 glomerulonephritis 0%, and nobody thinks that this is an FSGS. Excellent. Okay, this is the biopsy of the patient. And as you can see, this is more or less normal tubules, nothing going on in the interstitium. And this is the glomeruli. And they were, at least this group of glomeruli, they were normal. There is no mesangial expansion. The capillary basement membranes looks fine. There is no inflammation, and seems nothing is going on with this kidney. However, in other areas, the interstitium showed extensive foam cells. This is not fibrosis. This is what we call foam cells in the interstitium or foamy changes of the tubules. Usually you see it as a common change in nephrotic patients or patients with proteinuria, like in membranous, their common association in membranous, in FSGS, in conditions which are associated with heavy proteinuria. But this patient did have significant cells within his tubules, as you can see. And then there were only these couple of glomeruli, which were ischemic. You can see that the Bowman's capsules were thickened, and there is some change here with adhesion and sclerosis. And again, this is minimal sclerosis and capsular adhesions, and again, a slightly ischemic glomerulus. So this is basically what he had, only this focal ischemic changes with this mild or early segmental sclerosis, and otherwise nothing characteristic in the biopsy. So if I asked you, what do you think these light microscopic findings are of? I'm just talking about the light microscopy level. So if you see these pictures, what do you think? Does this pattern should be called FSGS, no change under light microscopy? Is this a membranous nephropathy? Is this acute tubular injury? It could be any of the above.
So
please vote.
Yes, for 1 minute, and then we will go ahead. So these are the results. FSGS 6, no change, membranous, and acute tubular injury. So we have choices for all selections. So do you like to go ahead?
So we have the highest for FSGS, and yes, everybody are good pathologists, because yes, this is the pattern I would pick. This is an FSGS pattern or an FSGS picture of injury due to the presence of the ischemic glomeruli and the segmental sclerosis in this age, because this is a young patient. I cannot call it no change under light microscopy. No, this is not membranous. The basement membranes appeared at least quite normal to call it a membranous pattern. Foam cells are not to be considered a form of an acute tubular injury. So yeah, what best fits this microscopic finding is FSGS. So we have a specific focal segmental glomerulosclerosis within this patient's kidney. So within this light microscopy pattern, which one do you think best fits our original differential diagnosis? Would this best fit IgA nephropathy? Again, Alport, C3GN, benign familial hematuria, FSGS, or you don't know and you would require further tests? So please vote. Yes, 20% for IgA nephropathy, 15% for Alport, 10% for C3 glomerulonephritis, and more than 50%, I don't know, further tests required. And what's nice about that is that actually the percentages of your differential diagnosis changed with the light microscopy pattern. So benign familial hematuria is 0% right now, where it ranked 3rd in the first clinical differential diagnosis. And yes, we don't know, further tests are required. So for this particular patient, which further tests you prefer? Would you like to have immunohistochemistry / immunofluorescence? Would you like to have electron microscopy or both. Again, vote, and that's the last time, I promise. True. Yes. So 75% picked both, which is expected, because we need immunohistochemistry to exclude IgA nephropathy. We need EM for Alport. We need immunohistochemistry for C3 glomerulonephritis. As you all basically changed your differential diagnosis within the light microscopy picture, benign familial hematuria does not fit anymore because it should be a normal, more or less a completely normal kidney. And if we are considering any form of FSGS, which could be genetic in this form, or in this special case, then you will need both immuno and EM. So the immunohistochemistry of this patient was negative for the routine panel, IgA, IgG, IgM, C3, because he is a child, we don't perform kappa and Lambda. So the list of differential diagnosis within the light microscopy and immunohistochemistry now actually changed. This is not an IgA nephropathy because the IgA and C3 were negative. This is not a C3 glomerulonephritis because again, there was no dominant C3 deposits. There were absolutely no C3 deposits. We've already excluded benign familial hematuria based on the light microscopy picture we've seen. So we're left with two options. Alport syndrome, which then requires laparoscopy, and FSGS, where I said we don't have any underlying disease for FSGS, and then EM. And to be very honest, clinically, this patient does not really fit into an FSGS. And as you've picked in the original differential diagnosis, nobody ever considered FSGS. And this is a very important point because if the patient does not clinically fit into an FSGS, then you need always consider that the FSGS you see within the light microscopy or within the pathology report is just a non-specific scarring of the kidney secondary to another form of an underlying disease. So we are actually left with Alport's syndrome. Let's see the electron microscopy. And this is the basement membranes. And you can see this is the podocytic surface. Here you have a normal food processes with segmental effacement. Again here, normal podocytes, normal food processes, segmental areas of effacement. The endothelium is fine with its fenestrine. This is an endothelial cell, but look at the basement membrane itself. You see that you have scalloping of the podocyte surface. Usually the podocyte surface of the glomerular basement membranes are straight. You don't get these, what we call scallops. And the basement membrane itself is more or less festooned and appears to be irregular in thickening. Let me show you another picture. Again, this is the podocytic surface. This is the endothelial surface. And look at the basement membrane. It's an irregularly thickened basement membrane. Its thickness is irregular. You have a markedly thin segment here, and you have a markedly thick segment here. So you have alternating thick and thin segments of the glomerular basement membranes. You have segmental podocyte effacement, and you have this festooning of the, or outpouching of the GBM with this scalloping towards the podocytic surfaces. Actually, this picture is highly suggestive of Alport syndrome with this irregular findings. Again, he had other segments of very thin glomerular basement membranes. And this area showed early basket weaving appearance and separation of the lamina densa and the glomerular basement membranes. And you can see also segmental effacement of the podocytes. So following the biopsy, audiometry revealed a mild degree of hearing loss. The patient was not considered to have any hearing defects. And actually in these patients, you always need to perform some form of audiometry because sometimes they're just not aware of it. And the screening of a younger sibling revealed also microscopic hematuria, which was not detected. So this is Alport's syndrome. So Alport is a hereditary disease of the glomerular basement membrane. It is not rare. Frequency is 1 every 5,000 to 1 every 10,000. It causes a glomerulopathy, hematuria, plus or minus proteinuria. This proteinuria can easily get to up to a nephrotic, a full-blown nephrotic syndrome. You have renal failure, patients usually progress to renal failure and impaired renal function, and you've got ultrastructural abnormalities of the glomerular basement membrane, as you can see in this picture, classic outpouching or festooning of the glomerular basement membranes with the basket weaving appearance, and I think these are some breadcrumbs. These patients have sensory neural deafness and have as well ocular symptoms. This is Alport. You have here, you can see the changes of the glomerular basement membrane. Again here, the marked outpouching or scalping of the glomerular basement membrane. Look here, you have alternating segments, thick segments with thin segments. And here again, look at this basement membrane. You have all of this thick basement membrane, and then you have a very thinned out area here. So what about the thin glomerular basement membrane disease? Why is this not thin glomerular basement membrane disease? This is a very important point that number one, this thin glomerular basement membrane disease was initially described in familial benign hematuria, but this is not a specific lesion. And it may be observed in Alport syndrome, mostly in young patients or in females. Some females tend to have, they have Alport syndrome, and you see that the majority of the glomerular basement membranes are actually thin. And then you detect only this segment with the ultrastructure changes, which are characteristic for Alport. Thin glomerular basement membrane disease is not a marker, or sorry, thin glomerular basement membrane itself is not a marker of a benign disease. So if I'm performing an EM in a patient with hematuria and I only see thin basement membrane, that does not mean that the patient does not have anything or that he has a benign familial hematuria. Remember, this is familial and benign familial hematuria. So you really need to add a lot of dots together to come up with a diagnosis. So a thin basement membrane is not a benign lesion, and it does not exclude the diagnosis of Alport syndrome. So if by EM you have only this thin basement membrane, that does not mean that the patient does not have Alport. It means that probably this is all what was sampled within your EM sample. Thin GBM has also been found in various types of non-hereditary disease, like, of course, IgA nephropathy. So a thin basement membrane is not always related to a hereditary disease. I'm not going to get into the genetic details about Alport because this is not a presentation, this is just a case, but I just want to remind you with the types of Alport syndrome, and that we don't have a single type, and that we could have eye, ear, and lung with different dominants, and we can also have skin basement membrane changes. This is the basement membrane, and this is the collagen chain distribution in normal human glomerular basement membrane. So we have the lamina rara externa, which is towards the surface, the epithelial surface of the basement membrane. And then we have this white line, which we call the lamina densa. This is the one intermediate. And then we have the lamina rara interna, which is towards the endothelial side. In the subendothelial chains, we have alpha 1 collagen 4, alpha 2, 4, and we have type 5 and type 6 collagen. In the lamina densa chains, they are all collagen 4. And because Alport is collagen 4 disease, you get maybe changes seen in the lamina interna and within the lamina densa of the glomerular basement membrane. This is the phenotypic class Alport syndrome. This is just to show you how many types of Alport we have. And the important point I want to highlight out here is that we have, as you can see, type 3 and type 4, which actually presents over the age of 31 years old, because you can have Alport as a first presentation in patients who are aged 50, 55, and 60 years old. You can diagnose and should consider and suspect Alport in patients above 30 years old, because you don't know which type of Alport they have and which mode of inheritance they do. The autosomal dominant one, which is type 5, is more dominant actually, or more prevalent in females, and females start presenting with this disease at also at an older age, but this is not really documented. And then we have the other type, and as you can see, the autosomal dominant one is not associated with any form of hearing loss or ocular defects. In relation to benign familial hematuria, we don't really know what is the exact prevalence of this disease. It's between 1 to 10%, although it is an autosomal dominant transmission, but there are also some sporadic cases. So it's not always this a dominant transmission. These patients present with hematuria only. The most important thing is that you have no proteinuria and no progression to renal failure within the course of this disease. And by electron microscopy, you need a uniformly thin glomerular basement membrane to diagnose this. So it's not a matter of finding a thin basement membrane. No, in order to call this case or to classify it as a benign familial hematuria, you need a uniformly thin glomerular basement membranes. Once you have segments of normal thickness or overtly thickened glomerular basement membrane, this is not a benign familial hematuria anymore. And of course, by immunohistology, these patients have normal expression of type 4 collagen chains. Also, although there were some segregation in females for also some mutations in collagen type 4, so there is probably some overlap with Alport. So in summary, I just want to highlight that Alport syndrome is not a disease of only children. This is also a disease of adults, and it can present at any age, dependent on the type of Alport and the mode of inheritance. It can present by variable degrees of proteinuria up to nephrotic syndrome, so it does not always have to be isolated hematuria. At the light microscope, lesions can be quite variable, but they are not specific, even if they can suggest the diagnosis of Alport. And yes, this patient's light microscopy did suggest the diagnosis of Alport, because usually when I see foam cells out of context of proteinuria, I mean, he has less than 1 gram proteinuria. So the presence of these foam cells always makes me think of Alport. Ultrastructure changes, of course, of the glomerular basement membranes are the diagnosis. This is what allows the diagnosis of Alport syndrome. And there were some centers, one of them where I used to work in Amsterdam. We used to do immunohistological analysis by immunohistochemistry of a type 4 and type 4 collagen chains distribution, and we used to stain for them in the kidney and in the skin. If the Alport syndrome is X-linked, and it used to allow the diagnosis, a non-invasive diagnosis of Alport syndrome in most patients. But you have to be careful that also that if you have a normal distribution of type 4 collagen chain, this does not exclude Alport as well. So it did help, but since it does not 100% exclude the presence of Alport, this is why not all centers use it. And I just will show you an example. This is from our work at the RMC, and this was the control. This is how collagen 4 stains distribution in the glomerulus, and this is one from an Alport patient. Well, I'll stop here, and if you have any questions, please raise your hand. We'll give 5 minutes for discussion before Dr. Hussein starts updating us and enlightening us on any updates on the management of patients with Alport syndrome. Thank you very much.
Thank you very much, Professor Wesam. It is very interesting and wonderful presentation. I'd like to hear from Dr. Sam.
Hi.
Hi, how are you?
Yeah, Dr. Ismail, that's a wonderful presentation. It's not an uncommon disease. I've seen these cases like maybe 3, 4 during my fellowship. And usually we do when we have like hematuria and kind of some hints in the light microscope, like FSGS or foam cells. And then the electron microscope, you will see some, like, as you mentioned, is like thinning and thickening of the base membrane. Usually we do the immunofluorescence for alpha 2 and alpha 5 chain. And we'll see most of the cases, we get like normal patterns of IF for alpha 2 and alpha 5. But we put some note or disclaimer, because approximately like 1/3 of patients with established hereditary nephritis based on typical ultrastructure findings and family history show loss of glomerular basement membrane. So normal staining pattern doesn't exclude the diagnosis of hereditary nephritis.
Yes.
So this is one of the things. It's even if it's normal by the IF for alpha 2 and alpha 5, this doesn't exclude. And as you mentioned this, but usually we don't use the immunostain. So usually use the IF in our practice for the alpha 5 and alpha 2. Yeah, but I think it's interesting case. Yeah, thank you very much. I mean, you describe it very nicely. I think you are. I mean, I've like for the audience, I've known Dr. Ismail for a short time, but I've discovered she's a great person and a great renal pathologist, and I wish we got her in the US here.
Thank you very much, Sam. That's very nice.
But we don't agree about this deal because Dr. Wesam Ismail is essential here for Egypt and for Arab world pathology.
Yeah, just wishes. It's just wish.
But we are honored to have you with us this night, and then thank you very much. And I'm going to hear from the audience, from Dr. Mohamed Said. Your comment, Dr. Mohamed.
Thank you, Professor Wesam, for the very nice case and very interesting. Just my comment regarding the family history of renal impairment or renal failure, I think it should be considered in the workup because this patient might have a feature of thin basement membrane disease and Alport, both of them. In the absence of high degree of proteinuria and the negative family history of renal failure, it might go with thin basement membrane disease, and some patients, they might present with sclerotic lesion in the light. So I agree with Professor Sami for the immunostaining. It might be necessary if the patient doesn't have a family history of renal failure to differentiate between the two diseases.
Well,
Thank
well,
you,
actually,
Mohamed. Yes.
yeah, this is not what we meant. It helps to do the collagen stain, but it is not going to tell you whether you have hereditary nephritis or not. So this is number one. Number two, if I have Alport, then there is nothing called thin basement membrane disease. The thin basement membrane, which is seen in these patients, are part of Alport syndrome. On the other hand, we say that if I only see thin basement membrane, I still should consider Alport. So Alport takes the priority over a thin basement membrane. So, so a benign, actually it's the family history which helps if you want to call it a benign familial hematuria. And if you have a normal distribution of collagen, that does not mean that it's not Alport. Some patients do have.
I would like to add to Dr. Mohamed Said that always we ask about family history. And this is one of the essential components of the history. Yes.
The first report, did not have any significant family history.
I'd like to hear from Dr. Saeed Al-Ghamdi. We missed him so much. Dr. Saeed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Prof. Hussein and Dr. Wesam for this excellent case. We have in Saudi Arabia quite large experience with Alport syndrome because the high risk of or the high consanguinity between families here, the marriage, where we see a lot of Alport syndrome. And to the extent that some area of the kingdom, we can actually diagnose the patient if he comes from certain family or from, and we find at least 4 or 5 members of the family, they are on dialysis. So it's really common in some areas. And right now we are resorting to whole exome sequencing to check for Alport syndrome. And we discovered that we had the type which is not the same with the world, like what, for example, being described with the West is, which is X-linked, but we have most likely here in the Saudi Arabia probably the autosomal type, where we have the father or mother has been affected, and some of the kids or siblings they are. And right now in King Faisal Specialist Hospital in Jeddah, we have embarked within the larger Saudi genome project on detecting all the renal disease, genetic renal disease in Saudi Arabia. And we discovered that most of our cases, which we called hereditary nephritis, actually, they are Alport syndrome. Interesting to say the same like what Sam said, there is little hearing deficit or eye changes. It's mostly just the renal involvement. And usually they present with renal failure at the age of third or to fourth decade of life, where they be on dialysis. So it's really what I'm saying, that quite common. And I introduced to you that whole exome sequencing, especially if you know the area, probably does not, actually it mitigates renal biopsy in our area here. And we do just the WAS to diagnose the disease. And it's quite simple, and we no longer do kidney biopsy for those kind of family who are coming from special area after doing WAS, whole exome sequencing. Thank you very much.
Thank you very much, Professor Al-Ghamdi. And I'd like you to just to wait with us until the end of this session, because I'm going to update the Alport syndrome update from the current literature, and all literatures are going to the stream of genetic testing. And I'm going to present some exciting ideas in the genetic testing. So would you please be with us until the end?
I will.
Okay?
Thank
you very much. Thank you.
Thank you.
Professor Said.
Very interesting, Said. It's really great data, and you should publish it soon so we can all learn. Because you also know that here we have a high rate of consanguineous marriages, and that probably these are the ones, as you said, they are autosomal dominant, and they do present at this late stage. So thank you very much for sharing the information with us.
And I'm going to also to present some of our experience from Mansoura here, from pediatric hospital. So this is also, I have data from Egypt. So Dr. Riyad Said.
مساء الخير. Well done, Wesam. I really have 2 points only. I'd like to ask Wesam, what about the foamy cells that you really stressed in the biopsy? What's its clinical significance in a patient with Alport syndrome? How frequently you do see such things? That's one. Secondly, we tend to forget about the family history. It's a custom, we only think about family history from the father's side. But what about the mother's side? Because most of the cases that we have in our area, and I'll see a good number of patients who are coming from neighboring Arab countries, especially from Iraq, and have at least a family of 20 persons already I have in my clinic. Most of them you have to ask about the mother's side. Uncle, what about the uncles? That's how we, the mother may have nothing really to do, but the uncles of the candidate may be really affected. Don't concentrate mainly on the father side, but talk about the mother side. Thank you.
Dr. Riyad,
well, thank you, Dr. Riyad. Yeah, the comment on heredity, on the family history is very valuable. In relation to the foam cells, no, they don't have any clinical significance. And some cases of Alport can show it and others don't. You usually see foam cells, as I mentioned, in patients with heavy proteinuria. So this is just a change from the proteinuria. But if I see foam cells in a patient which is not heavily proteinuric, then it makes me think that this patient could be Alport. This is all. Other than
because
that,
this amount of protein was 0.9 gram, 0.9, less than 1 gram. Yes.
Exactly. So yeah, that's the only thing that it can make you suspect that you could be dealing with Alport syndrome. It's only a suspicion, because at the end of the day, there is no characteristic finding in the light microscopy. That's all.
Dr. Riyad, regarding the family history, it is not father only. And we learned it a lot from the pediatricians to how to construct a pedigree. And the pedigree is father, mother, and grandfather, grandmother, and the whole family. So this is a good point to learn and to ask in details about the family history, not only in not take it a light way.
I think so.
Thank you very much, Dr. Riyad and Dr. Saeed. Khamis, the last comment. Dr. Saeed. Yes, I hear you.
Okay, thank you, Professor Wesam. I have one comment and 2 short questions. The comment regarding the hearing loss, I should send a message to my junior colleague that hearing loss doesn't mean that the patient doesn't hear me while I'm talking, because it's high frequency deafness. So I should do as you said, the
audiometry. Yes, audiometry.
My first question, did you do the blood smear, peripheral blood smear, blood film? Because there are more rare syndrome like Sebastian, like May-Hegelen, and Fleischner, that characterized by macrocytopenia, and the last one characterized by also leukocyte inclusion bodies, what's called bronze cells. Because the pattern of inheritance is different in these syndromes, which are subtypes of Alport?
Dr. Said.
The patient having what's called dysphagia or not, because sometimes leiomyoma can be there in the esophagus leading to dysphagia. Thank you so much.
Thank you very much, Dr. Said. Dr. Wesam, would you like to add any point here?
Yeah, I think I didn't hear well,
Okay.
but I think you were asking about any form of peripheral blood smears abnormalities, right?
Yes,
For,
yes.
yeah, as I understood, the patient's workup for all these diseases was normal before they proceeded with the biopsy. So he didn't have a problem
You
with
mean
the...
it is macrocytopenia or white body or cause?
No.
What about dysphagia? There is no dysphagia? Dysphagia.
I don't think so.
Okay, okay. Thank you.
Thank you very much, Dr. Said, for your comments. Do you see my slides, Dr. Wesam?
Yes.
Okay. So before I'm going to highlight some new ideas and updates of this disease, I'd like to thank and appreciate the efforts of Professor Wesam. Really wonderful, very professional, and I think this is the excellent template to go through. Just to highlight some ideas about this membrane, I would like to refer to this article, which is published and is still in press, Nature Review of Nephrology, about complexities of glomerular membrane. And it is very nice. And I think Professor Wesam presented the structure of this membrane. It is quite complex, including many collagens, and some of them are abundant, some of them are minor contributing, but the structure is quite complex, as you see. And I'd like to stress upon the even this membrane there, and it is not left without collaboration with other structures. So the glomerular filter includes the podocytes, this membrane, and the epithelial cell. All of these coordinate together. And more importantly and more interesting is by age, there are evolution from early, maturing, and the mature basement membrane and glomerular filter. So in early stages, this is the structure of this membrane. And as you see, the composition, podocyte maturation, endothelial maturation, all the filter in the early phases of maturation. And in the maturing, with maturing, you'll find the structure, more refinement of the structure. Dr. Riyad, so with maturation, this is the change, and with mature form, you'll find even the issue is more complicated toward the normal structure that we are accustomed to have. To make it very simple, this is a normal filter, capillary filter. You'll find podocytes are fantastic, and this is how it rests on the basement membrane. The slit diaphragm are there, endothelial cells and infiltrations, everything is normal. And the thickness of basement membrane is normal. So this is a normal glomerular capillary wall. Look at Alport syndrome as elegantly shown by Professor Wesam, and I'm going just to repeat what she said. This is the podocyte. You can find the podocyte effacement, which is not specific for Alport, and it can be seen with the minimal change or FHS. But what is more important and more specific is the abnormality of both basement membrane and podocytes. You can find here basement membrane splitting, lamination, irregular thickening. You can find some of the basement membrane areas are thick and some of them are thin. And look carefully here, the podocyte you can find the podocyte here protruded within the basement membrane, and you can find the basement membrane protruding here in the podocyte, so it is out pocket. So this is, and there is podocyte protrusion. So the Alport syndrome is characterized by abnormality of the filter, and the appearance of basement membrane is very interesting to be addressed. In thin basement membrane disease, and another names, thin basement membrane nephropathy that may be associated with any form of nephropathy, the whole The full-blown histological is the thin basal membrane. So the basal membrane is regular, but thin than the normal basal membrane. And you can find some podocyte effacement, but again, you can see the great difference between basal membrane nephropathy or basal membrane and thin basal membrane and Alport syndrome. One of the very nice articles in the American Journal of Kidney Disease, early diagnosis and treatment make a great difference, as Professor Al-Ghamdi mentioned, that studying the inheritance and the genetic testing by the available genetic testing nowadays in many centers worldwide characterize everything. So we have mode of inheritance. It may be X-linked, autosomal recessive, compound or dominant, diagenic and suspected, and this is the affected genes, and this is how the state is going on. What are the indications for genetic testing for Alport syndrome? Persistent glomerular hematuria plus one of the following. Clinical findings: sensory neural deafness, as Dr. Saeed Khamis mentioned, it is by audiometry, anterior lenticonus and or characteristic retinopathy. So this is a disease that needs a multidisciplinary approach between our specialty and others, and the ophthalmology or the NT. Family history finding hematuria. So it's important to ask about the spread of renal manifestation in the family, the presence of CKD, kidney failure, deafness associated with CKD, pathological findings on the kidney biopsy, negative or non-specific routine immune fluorescence, as Professor Wesam showed, the absence of IgA and other immune fluorescence. So by this way, we can exclude primary glomerular diseases. Thin glomerular basal membranes, characteristic glomerular basal membrane thickening, lamellation, and scalloping. Other steroid-resistant FGS as part of this genetic, as Professor Al-Ghamdi mentioned, next generation sequencing, whole exome sequencing, a lot of tests, and I'm glad that all these tests are available in serology. What are the pros and cons of the genetic testing? There are many advantages and some limitations. Advantages are to confirm the diagnosis. Genotyping has implication for prognosis and monitoring, identification of at-risk relatives, predicting risk for recurrence in the future pregnancies, and to personalize treatment. And I think this will be in the future with development and advancement of the basic research to have drugs that work in this issue. The limitations, approximate 10% of patients with clinically and pathologically confirmed Alport syndrome have mutations that are not identified by these genetic testing, either next generation sequencing or whole exome sequencing. The significance of some variants will be uncertain. We don't know. Insurance coverage is variable, and the availability of the test, access to genetic counseling is variable from country to country and from center to center. One of the very exciting ideas from the update is the issue of pre-implantation genetic testing for monogenic kidney disease. I think it's very exciting, and I'm not sure from the religious aspects how does it go, but I think if we go to the before implanting the zygote in the in vitro fertilization, after the zygote, and we can test the presence of monogenic kidney disease within this tube before implantation, then we can select the best healthy zygote to be implanted. And I think it's very exciting issue. And for this work that was carried out at this center, it is a retrospective study at Maastricht MBC, where they started the journey of pre-implantation genetic testing from 1995, and this is the harvest of their experience in this period of time until June 2019. And the couple counseled on pre-implantation genetic testing for monogenic kidney disease. The most frequent indication for referral are adult onset diseases, either autosomal dominant polycystic kidney disease, and Albort in 26%. So it is not exclusively a disease of young. It may be encountered in adulthood, autosomal recessive in 9%. And the most exciting is counseling in this center experience on pre-implantation genetic testing for kidney patients is essential to allow, this is the conclusions of the authors, to allow patients to make their own choice, either to continue or to get rid of these abnormalities. If couples proceed with pre-implantation genetic testing, outcome are generally favorable. And I remember a case that I was confronted by since a long time. She was a case of Finnish type FSGS genetic, and I discussed with the mother that we may need to do in the subsequent pregnancies amniocentesis and testing for the anomalies, and then to terminate pregnancy. I think it's very exciting if we know from the beginning, before the journey of pregnancy, how to proceed. So one of the practical issues in this review about how to go in the workup for patients with persistent glomerular hematuria with normal serum complement. Clinical pedigree data suggests the diagnosis of Alport, so family history for the father family and the mother family is important. And then genetic testing, either the presence of the pathogenic variants, if it is identified, managed at Alport syndrome by offering regular follow-up and starting ACE inhibitor in all proteinuric patients. If there is no variance or benign variance, then we can go to kidney biopsy. And if the clinical pedigree is negative, we do biopsy. And the kidney biopsy suggestive of Albort, managed as Albort case by ACE inhibitors that reduces the stress within the glomeruli, and proceed to genetic testing if not already done. The findings are indicative of non-Albort disease, we treat accordingly. So this is a very simple algorithm. This is a nice study. It is a multi-center randomized placebo-controlled double-blind phase 3 trial with open arm comparison indicating safety and efficacy of nephroprotective therapy with ramipril in children with Albort syndrome. So this is the number of patients, as you see, minimal number at the end of the day, documenting, and this is the baseline oligo-symptomatic or asymptomatic children. Number is 6, age 2 year or older, preemptive stage of disease with isolated hematuria or with microalbuminuria. Estimate GFR is normal, normal blood pressure, everything is normal. And then testing the safety and efficacy of ramipril in this early stages of the disease. And they, in this study, although the sample is restricted, and the study confirms the safety of using ACE inhibitor, ramipril, and shows some efficacy, although p-value is statistically insignificant, but I think it is clinically significant to the extent that the conclusion, early initiation of ramipril showed no safety signals, no problems from the safety side, and preemptive therapy appears to slow early disease progression and may justify screening of patients with isolated hematuria for Alport-related gene variants. Regarding our experience here at in Mansoura University, this is not from Urology and Nephrology Center, it is from Children's Hospital, Pediatric Glomerular Hematuria Clinicopathology Study, published by Professor Fatma Husseini and the others. This study included 95 children presented between 2013 to 2019 with gross or microscopic hematuria with or without proteinuria, in whom non-glomerular causes were excluded. And this is, at the end of the day, this is the diagnosis of these 95 children. 63 are Albort syndrome, 28 Thymus membrane related disease, and 4 IgA nephropathy. And this table shows the demographic criteria. I'm not going to read them, but it shows the clinical presentation, recurrent gross hematuria, persistent microscopic hematuria. You will find this is in the same membrane disease. In the Albort syndrome side, you can find plus hematuria, some proteinuria, as you see in this slide. I'm not going to bother you by the details, but this is from the histopathological findings for the how to diagnose Alport syndrome, and I think it is shown very clear and by Professor Wesam, and this is thin basement pain and IgA by the presence of IgA. Favorable criteria and unfavorable criteria in this cohort of patients. If there is this is the significant ones, persistent proteinuria. So the presence of persistent proteinuria plus hematuria is bad news, as you see here in unfavorable outcome and the progressive diseases. It was present here in the majority of patients. And if there is a reduction of GFR at the time of presentation, this predicts unfavorable outcome. Let us go. I have 2 minutes and stop. This is the table that shows current and investigative therapies for diseases with glomerular basement membrane involvement and mainly Alport syndrome. So RAS inhibitors, ARBs, aldosterone receptor blockers, or S inhibitors, reduction. The main mechanism is reduction in intraglomerular pressure, and this is a current standard of care. And I demonstrated the article that earlier use of RAS blockade may make a great difference. And then therapies under development, either targeting fibrosis. So there are ongoing studies of anti-microRNA 21 oligonucleotide. This is to arrest the progression of disease by targeting fibrosis. So reduce fibrosis in Alport syndrome by silencing microRNA 21. The preclinical study, and we are waiting clinical evidence. Type 4 collagen inhibitors, I think it will be fantastic to deal with all these. Advanced glycation in the products, this is in diabetic rat model, because in diabetic kidney disease is a disease of basement membrane. I'm not going to discuss this. And the extra, the matrix biology manipulations through gene replacement therapy, inducing expression of GBM genes. All these are exciting ideas, or chemical chaperone-based therapies. All these are advances in the preclinical stage. And I think from this is how they manipulate the gene, either gene editing technology, protein linkage-based repair, or protein replacement. All these are preclinical and basic research. But what we have is early diagnosis. And I agree with all the comments. We should ask about family history for every case. And I think the threshold for doing the biopsy, if we don't have genetic test available, the threshold for doing a biopsy for patients with isolated hematuria, and I think this is the question that will, I'm waiting your comments about this issue, because since many years, our policy not to do biopsy if there is isolated hematuria, and we will follow the patient if there is any development of proteinuria or progression of the kidney with reduction of GFR or rising creatinine, we do biopsy. I think it's better to do biopsy if we don't have a genetic testing. And at the end of my presentation, I would like to thank Professor Wesam Ismail, and I think we will be together in the clinical pathological correlation, because I think it is fantastic. And I should stop here for your comments, but this is a symbol of appreciation and respect for Professor Wesam Ismail for preparing this case and for all what she delivered this night. Thank you very much, and I'll be happy if you have any comments or any questions. Dr. Wesam. Unmute yourself, Dr. Wesam.
Well, thank you very much, Hussein. Excellent sum up and summary as usual, and a very enlightening update. And yes, in relation to the data you presented, and that these patients could benefit from early intervention and from ARBs. So I think if we don't have available genetic testing, which is still quite expensive in some areas, then an isolated hematuria patient should be biopsied and not just followed up.
Dr. Said? Dr. Al-Ghamdi.
Thank you, and I really I learned. Thank you very much, Prof. Hussein. I learned a lot from this case and from your presentation, which enlightened me about the value of various diagnostic measures, and including biopsy sometimes might be necessary because there might be some other pathology going on. As I said earlier on, we have our research going on, and we have, at least we have what 60 cases of Alport syndrome already genetically tested. We take actually just the index case. We don't take the family member because there's so many in the society there. And I think probably by the end of this year, probably we'll have some data to satisfy Dr. Wesam Ismail request to think about publishing it. But we have the most interesting thing, among all of genetic disorders we had in Saudi Arabia, Alport syndrome came first from all WS testing which we made. To a lesser extent that we had some rare tubular dysfunctions like the hypomagnesemia, hypercalciuria, familial hypomagnesemia syndrome, which causes stage renal disease. And we are about to publish the case now, and it's in the press right now. So just I want to say that genetic testing probably is coming big in this subject. It will be the same like the Belal RA for membranous nephropathy in the future. That's my understanding and my vision about the future of this disorder. Thank you very much.
I would like to ask you, Dr. Said, about the transplantation of Alport syndrome patients. Do you witness any acquired anti-GBM after transplantation?
Honestly, that I heard about one case. I wasn't following it, but only one case from one of our colleagues who mentioned to me that the patient developed this one. But from my own series, transplantation is okay, and we have no problem. I have many of those members of the family, they are transplanted, and they're doing well after 10, 15 years from transplantation. So it's not necessarily that they will develop anti-GBM, but certainly we have to be on alert that they might develop this disorder.
I asked this question because we have a good number of patients, but I'm not remembering the actual number of the hereditary nephritis Alport syndrome transplanted in our center. And always we put this in mind because we read it in the textbook that acute allographic dysfunction may be due to the crescentic or acquired anti-GBM, but we didn't diagnose any case of linear or acquired anti-GBM after transplantation, and the graft dysfunction was diagnosed as rejection and others, and not acquired anti-GBM disease. Dr. Riyad Said, do you have cases of Alport transplanted?
Well, thank you. Yeah, thank you. We have, I'll say, maybe around 10 in our series we transplanted, but really none of them, they developed anti-GBM antibody disease. But it's being reported. I did not see it personally.
Yes, this is the same. That we didn't find any case. And we learned from our experience, if the donor came with hematuria, not to accept, even if it is the only donor with the age that may be accepted, we don't accept this donor except after doing the biopsy. And we documented the presence of hereditary nephritis in some of these donors, so we stop. If we have a donor, potential donor with persistent microscopic hematuria, we don't accept to proceed for kidney donation. But
well,
okay.
Well, I don't think that really a patient with hematuria persistent, and especially it's coming to donate for his family member, and if it's proved to be some family Alport syndrome, I don't think that really it's feasible or it's wise, at least on our part, to do a kidney biopsy in the donor to say, well, you are fit to donate a kidney. That's really out of my practice. I don't know Saeed Al-Ghamdi, what he thinks, Faissal Shaheen, and our group in Egypt.
Okay. Dr. Said, you like to comment?
Well, actually, same. I must say that I agree with the Professor Sheashaa and Professor Riyad that we are a little bit careful when there is a genetic history of a disease inside the family, not to ask them for living-related transplant, and even sometimes discourage it. And even if there is no microscopic hematuria, when there is a family history, certainly you can do kidney biopsy and make sure about this one. But I have noticed that over the years that we have many families who donated to their loved one, they ended up with end-stage renal disease, which suggests that the penetrance of genetic disease in our area is different from what we've been reported, and we have to be careful about taking living related in those individuals, and at least not to encourage it strongly. You have to be at the alert that they might have disease which is still in the burning process.
This is what we do. We will not do biopsy for a potential donor except if there was no history in the family. Okay. Dr. Faisal?
Thank you, Hussein. I enjoy this excellent case and how the pattern that this case being discussed through all the tonight, and thanks for that, for all of you, for the effort. I do agree 100% with Saeed. Actually, he brought our experience in Saudi Arabia with so many patients with Alport syndrome, and probably we had the time where we should check immediately audiometry for any patient who had hematuria in order to exclude Alport, and also to go for the genetic, which they are doing now at King Faisal and in many places also in Saudi Arabia. We have so many patients, usually family is coming. When I was in Jeddah Kidney Centers, I have 12 family with Alport syndrome because the number was huge. I had 650 patients on dialysis at that time, and I have 12 families. All of them are father with 2 kids, mother with 2 kids, or 3 kids even, going together, living together. So it is a problem. Mainly, it is a problem in Saudi Arabia, and probably we don't need to go for biopsy now, especially when the case is clear. Thank you. I appreciate what about this effort of this excellent meeting, and I hope that we can have it in the future with the same pattern. Like what Dr. Wesam mentioned.
Thank you very much, Professor Faisal. Dr. Yasser Al-Mula. Yasser.
Many thanks. Excellent talk. Little to add. We saw a total of 2 cases of anti-GBM following transplant of Alport syndrome, and that's out of 98 patients that were transplanted in the last 20 years in the UK. And both of these were published as posters. However, there was an argument whether they got it because of the Alport or they got it because of the CAM path, because all of us are aware that there is an association and a case report of anti-GBM disease following the CAM path. So whether it was because of this or because of that, it is not very clear. And in our center, at least in Edinburgh, there is always a controversy when one of the family donor is having like a non-visible microscopic hematuria, and we end up doing a biopsy and it turns back as a thin basement membrane. We always try to turn the patient down as not for donation, but we had two cases in the last 10 years who managed to donate to their family members and their underlying disease was thin basement membrane. But I'm aware that there is a controversy whether those patients should proceed and be assessed as donors or not. We tried our best to convince them, but both of them were adamant that they must donate, and they both got the non-visible hematuria, and on the biopsy it was thin basement membrane. They both went through an extensive genetic counseling and genetic testing before allowing them to donate. But to be honest, the outcome so far is very good for both of them. One is 7 years and one is about 10 years, if I'm not wrong, and they're doing very well. Excellent talk, and the new style is really good. Many thanks.
Thank you very much, Dr. Yasser, for this excellent experience. Dr. Dawlat Belal, would you like to comment?
And the excellent case, but it's really a little bit perplexing because we used to deal with cases of these recurrent hematurias, painless hematurias with positive family history, and we just conserve and presume that they are thin basement membrane disease and that they don't proceed to end-stage renal disease. However, from the discussion today and the talk, you are encouraging every case of one of these hematurias is to be biopsied and to the extent of electron microscopy. So it's really changing a lot of concepts for the practice. And in the same time, the conclusion that we probably don't take a donor from the same family, even if he does not have this microscopic hematuria.
And I think this is the very good message to be conducted. We should be careful about hematuria because, as the series presented from the pediatric hospital here, the majority were Alport syndrome. So to respect and there was no proteinuria and the kidney function was fine, and the pathology in the majority of these cases was Alport syndrome. Dr. Wesam.
Oh, yeah, I agree. And I agree with everybody. And thanks for the very good feedback. And there is only little to add, but to sum up, yes, it's not an uncommon disease. It's much more common than what we think. And yes, the recent tendency is that you don't consider thin basement membrane disease a disease except when you exclude Alport. And as Yasser have kindly mentioned, that in these patients, you need really to do extensive genetic testing, and you really need to make sure that they are thin basement membrane disease. So no, isolated hematuria would actually, at least in my opinion, present Alport. This is what we see more in our biopsies. I haven't really gone back to the database and see how much cases, but the common form definitely is Alport syndrome. Thank you very much, everybody. Thanks for joining us tonight. Thanks for the feedback, and hopefully we will see you next time, next month. Hussein?
Thank you very much. Appreciating your efforts. Dr. Sam, do you like to add any points before closing the session?
Yeah, thank you very much. That's an excellent, this is my first time here, but it's really excellent, high professional discussion. Correlations with the pathological from Dr. Ismail, it's really nice. And also the clinical correlations and all the articles are very nice. I just want to add a small, I don't want to take your time, but usually these cases, if it's hematuria and you expect there is thin basement membrane or Alport, you will do all the workup for it. But usually some small populations of these Alport disease present as a kind of FSGS pattern. As you mentioned, the patient present with the FSGS proteinuria, a little bit hematuria, and the clinicians treat it as a primary FSGS. And it's steroid resistant. They do biopsy, and because of renal, it's easy to be missed because you see FSGS lesion, and there is in the electron microscope, there is a thickening. You see there, this is ischemic changes from FSGS. So it's easy to be missed, especially with not a lot of hematuria. So always pay attention and put, even if it's uncommon disease, put this is in your differential diagnosis, especially if it's young age and you see foam cells and long-standing proteinuria and FSGS. Always exclude these possibilities when you're doing renal biopsy. Yeah, thank you very much.
Really,
thank you very much,
Dr. Sam.
It's very, very true. This is why I added FSGS in the differential diagnosis from the beginning in this case. But thank you very much for highlighting it.
Thank you, Dr. Sam, and it is an invitation for you, even if you have interesting case to discuss with us or to have a presentation with us, you are welcome at any moment according to your time.
Yeah, sure. I'm looking forward. And and hopefully in the future I can meet you in person. I like to come to Egypt and see you in person.
You're welcome every minute. Thank you very much. Thank you. At the end, I'd like to thank and appreciate the efforts done by Professor Wesam. Really wonderful, fantastic. And I think this is the professional platform that we should follow. I'd like to thank all the audience, my professors and colleagues from all countries. It is a very wonderful night. Thank you and goodbye. And the video will be uploaded tomorrow morning. Thank you and goodbye. Bye, Dr. Wesam.
Thank you, everyone. Bye-bye. Good night.
Dr. Faissal, thank you very much.